Five, four, three, two, one. Hello, everyone, and welcome to this session of the Fins Global Visiting Professor. Just sharing the screen. So this is done every 2 months, and today we have Professor Gail Rosseau. We'll be speaking about the current management of pituitary tumors. Professor Gail Rosseau will be introduced by the host today, who's Dr. Juliet Sekobunga. Dr. Juliet Sekobunga is a FINS fellow from 2017. She trained initially in Uganda and then went on to as a Bassett fellow to train in the US and then in Canada in Toronto. So Dr. Juliet, please go ahead.
Thank you very much, Sydney. I'm honored to actually be a part of this. I'm somewhere in the outskirts of Kampala and really honored to have been one of the Bassett's Fellow, honored to have been one of the FINS Scholarship Award, honors. So it was such an honor. And this afternoon in Uganda, this morning in the US, I am humbled and honored to actually introduce one of my great, can I say mentors, one of those people that I greatly admire, one of those people that I look to. Hopefully, when you say one day I want to be like so and so, so hopefully I would love to be like her one day. I've seen her in person once in Kampala, we met, and I know that she's at the University of California and of Washington. Sorry about that, but she's a skull-based, teacher, trainer, and I'm really glad to introduce Professor Gail Rosseau. And also, when it comes down to Africa, she's one of the examiners of COSEX, and we greatly honor that. I'm humbled and always humbled to introduce Professor Gail. Yes. Greatly honored to introduce her for this webinar.
Thank you very much, Dr. Sekobunga. Thank you very much, Dr. Ulrich Sydney. I'm delighted to be here and really pleased and honored that we are developing this FINS global community. That's the whole point of this. The vision that we had, those of us who serve on the FINS board and our friends of FINS, as well as our FINS, CLAC, and Bassett fellows, want to create a global community of teachers and learners together. So that is really the point of why we launched the FINS Global Visiting Professor Series. This is the second in such a series, and we will be doing them every second month or 6 times in 2021, and hopefully it will become a monthly event in 2022. But the idea behind it is to continue conversations across the world, and especially across all who are, we all at some point in our life are learners, then teachers, and then the best teachers are teacher learners, right? Where we're always refreshing, always coming back to learn and teach together. So I am really grateful to be part of this series, and I'm especially grateful to Juliet and to Ulrich for helping organize it. Let me just make sure that I can get to my next slide. So Juliet, thank you for that very warm introduction. And what you all will all see in the months to come are flyers for this series of talks that I just mentioned that look like this. And this logo was chosen by the young people in neurosurgery because it looks like neurons. It's a way of both traveling and connection that makes me think of both neurons and also metros, right? So we're traveling in our minds to meet one another's thoughts and to educate one another together. So I am humbled and honored and just really pleased to be with all of you today. I plan to give a talk of about half an hour, and then hopefully we'll have lots of questions and discussions. Because this is a sharing event, I wanted to share a little bit of where I'm coming from with all of you. I am originally from Chicago. That is where my home is, where I grew up, where my family is from. And that's a picture of Chicago, our city on the lake. And I hope that you will come visit. But I also did my training, both medical school and residency in Washington, D.C. And as you know from the introduction, I'm clinical professor of neurosurgery at George Washington now. So I spend a lot of time there. And then my heart is in the countryside in rural Connecticut. And in fact, that's where I'm speaking to you from now. If you take a look at where New York and Boston are, and right along the Connecticut River on Long Island Sound in Old Lyme, Connecticut. And that's where I'm speaking to you from now. And I hope to see you in your homes and my homes in the years to come. So we're talking about transsphenoidal pituitary surgery over the next few minutes we have together. And these are the things that I would like to address. And I hope that as we go through, you might put some notes down about how you do it. Are you able to see my slides? If you are not, it looks
no,
like.
Unfortunately.
Oh, well, let's launch again then. It sounds like you did see them and now you don't. I'm going to escape and try loading them again. If I get disconnected, I'll come right back on the call. Thank you for letting me know this.
Interesting, even 4 to 6 months later, you can see there's still interferon gamma in these tumors. So there's this chronic interferon gamma.
Can you see them now? Are you
No,
able?
not yet.
Not yet. That's interesting. You could at the beginning, so I'm not exactly sure where that's coming from. I'm going to escape again. I'm going to close the slides and start the talk again and see if I can just start sharing again from the beginning. Again, if I lose you, I will come right back on. So I'm going to start screen sharing again. And let's just try that again and see if it will work. It does say I'm screen sharing, but you don't see the slides. Is that correct?
Correct. We can't see the slides.
So Ulrich, that happened, I think, when we threw from your slides to mine. Is it possible that if you click stop share, that mine will appear?
Yeah, Eric, please make her the co-host. I think it's better to make her the co-host.
If not, I can get out of the meeting and come back in as a new host. But if you're able to either stop sharing or make me the co-host, it might be.
I'm not sharing. I just made you the host. Can you?
Okay, so
you can share.
I'm going to stop sharing and start sharing again and see if that makes a difference. Can you see now?
Yes, Prof.
Yeah,
Click on
yeah, we see your screen now.
Okay,
can
so
see the
you
screen.
see my screen, but I don't, and that would be helpful, wouldn't it? So what I'm going to do is I'm going to jump off the call, jump back in, screen share, and see if that works, okay? I'll be right back. So there is an assign and leave function, Ulrich. Do you want to
Yes.
assign me to be the host?
Yes, yes.
If you do that, I think we'll be in good shape.
So I assigned you as the host now. You're the host of the webinar.
Okay, very good. So I'm going to try sharing again now. So that does not seem to be working. I'm going to leave the meeting and come back in. I think that's the best way. Okay, I'll be right back.
Your microphone is muted. Professor Rosseau, your microphone is muted.
Ulrich, I'm back and I'm trying to share screen my slides. It does say I'm sharing, but I cannot see them. Can you see them?
No, we can only see your desktop, but not the screen. Perhaps what we can do is, if you send me your slides, I will share them from this end. And then we'll get.
Just click on the slide. Where is the presentation saved? Just click on it and.
I'm going to try that one more thing.
Yeah.
Can you see them now?
Yeah.
Yes, we can.
Okay.
Perfect.
Okay. There we go. Well, I'm really sorry about that. I thought that I had made every mistake possible on every video platform, but that's a new mistake. So, at any rate, I'll try to make up for lost time. Can everyone see and hear all right? So we can move forward. Thank you, and thank you, Dr. Dempsey, for joining us and for letting us know about that. He's our technical wizard in all these things. So thank you. Anyway, let's start talking about pituitary tumors after we look at that nice picture of Juliet again in my home. Okay, so these are the 5 things we want to talk about this morning. The diagnosis and indications for surgery, the OR setup and angle of approach that are so important to guaranteeing successful surgery, how to do the tumor resection, the closure, and the post-op care. Just 5 elements to think about today. So one of the things that I like best about this topic and about pituitary surgery in general is that pituitary surgery requires us to use so many elements of our broad medical education in addition to neurosurgery. It requires that we recall endocrinology and ophthalmology and otolaryngology. And so in that sense, it just encourages us to be our best selves, just like this recent COVID pandemic has, right? We've had to remember a lot of general medicine and remember and respond to the call that we are doctors first. So when we think about pituitary surgery, I hope that this message comes through loud and clear, and that is being a good neurosurgeon starts with being a good doctor who recognizes what the indications are for surgery. These are not just tumors to be removed and think about the technical aspects of them, but it's really management of a patient's problem in its entirety. So the first thing, and I give you just one example of how this is important, is a case that was actually sent to me. If you look at that picture on the left, you know, I do pituitary tumors, so people send me pituitary tumors. And if you look at that in a busy clinic, that image on your left, you might say, here's another pituitary tumor. But I encourage you to think about the broad picture. This patient needed lab studies. All patients do. We don't get worried about the potential concerns about optic nerve compression here before we do things in a sound methodological order. And this patient needed lab studies, which you can see how it turned out. The patient had primary hypothyroidism. So that degree of pituitary expansion was just secondary in the result of primary hypothyroidism. So this is a very good result that I can take no credit for because this patient never had surgery. They just had appropriate treatment of their endocrinologic pituitary problem by the neurosurgeon. And then here again, this is maybe a different kind of problem. Here in this case, all the pituitary and endocrine labs are provided with the patient who has a microprolactinoma. And it's a great case to do. And one could argue that doing this operation might be a chance for lifetime cure in a young person. But in most situations, an inexpensive and readily available medication that's given 3 times a day or sometimes 2 times a day called bromocriptine will manage that problem quite nicely. But there are cases that are so large that we recognize fairly promptly that they are going to require surgical treatment. And in macroprolactinomas like these, where there is either bony invasion, as you see on the one upper left, or where a large amount of the volume of the mass is cystic or hemorrhagic, so that no degree of anti-neoplastic medicine is going to help. And certainly no radiation is going to help. These are surgical problems. And certainly the patient from Iraq that you see below gives you an idea of what happens over many, many years when someone has a non-functional pituitary adenoma and doesn't have the opportunity for surgical treatment. So we're talking a lot about indications for surgery, and those patients all came with either imaging or labs or both that give you a little bit of a clue. But I show this case that was written about by one of my patients who happened to be a university professor, and it just shows the fascinating multiple ways in which a pituitary tumor, in his case, his acromegaly, could present themselves. So this man wrote up his story and it was published in the New York Times. So in a lay journal, he presented with insomnia and then sleep apnea. And then became diabetic and hypertensive, even though he was a fit 45-year-old university professor who bicycled to campus to teach every day. And when he found himself in his mid-40s sitting in the orthodontist chair getting braces, he said, there must be something wrong. Now, this is someone who was seeing a lot of doctors, but they were a lot of different doctors and no one could put it all together. So this is where neurosurgeons who are really thinking broadly about pituitary disease will really be able to offer a lot of help to a lot of people. And as you know, autopsy studies show us that 1 in 5 people have a pituitary tumor. Now, not all of them need treatment, but it's very common. So we want to be able to recognize the multiple types of syndromes that can come to our attention. And then we'll say a few words about our father of neurosurgery, Harvey Cushing, whose syndrome, or disease, I should say, was so many and varied as to baffle analysis at that time. We've learned a lot since then. But I hope I've made the point strongly that we are not just pituitary tumor jockeys. And this talk is intended to have us think mainly about how to be expert in the management of these cases. We can have other talks that have a lot more detail about our surgical function. So once we have identified that a patient has a tumor and we have imaging and we know if it's endocrinologically active, we want to have an idea of whether it is affecting their vision. And you're all familiar with the classic bitemporal hemianopsia of pituitary adenomas, but there are many varieties and variations on that we want to be familiar with. I'm very proud that pituitary surgery was one of the first areas in which neurosurgeons showed global leadership during this current pandemic, because it was necessary to sort out how could you safely do surgery through the nose into the brain during the time of a respiratorily transmitted pandemic. So hats off to our colleagues who worked with us on that. So let's talk a little bit now about how we set our patients and ourselves up for safe surgery. This is generally done if one has the choice and has technology to make it safe. It is now normally an endoscopic rather than a transcranial approach. And the endonasal approach is generally preferred. But we want to remember that it's keeping things safe that is most important. It can be done with 2, 3, or 4 hands, and very often these are teams of a neurosurgeon with an otolaryngologist or of a senior neurosurgeon with a more junior one. And I'll give you a hint. Sometimes it's the more senior one who is holding the endoscope and the more junior one who's actually doing the operation, because safe visualization is the key toward this surgery in particular and any type of keyhole approach in general. You want to be sure your angle of approach is correct so that you don't angle inappropriately to cephalad and find yourself in the anterior fossa. And you have to insist on a clean lens. So I want you to look at this skull that's in the middle and then the schematic that's superimposed on it, and always be thinking that whatever route you take, whether you use specula or not, whether you use an endoscope or not, 2-hand, 1-hand, transbuccal, transeptal, this is the view that you must have, and you must have it safely and clearly. And that is, you must have a window of exposure that has the 2 sphenoid sinus ostia in the upper outer corners. And when you open the into the sphenoid sinus in that fashion, your trajectory will always be safe. So this is what we're looking at. Try to remember to have that mind's eye view of what you're trying to get at. You see that in the cartoon at left. You're visualizing a tumor within a pituitary on the right, and you're even thinking ahead to what the histologic section is going to look like of that successfully removed tumor. So this is what we want it to look like as you are trying to reach. Are you able to see that video? And so we've identified the two sphenoid sinus ostia, and we're removing the rostrum of the sphenoid. Remember, we're not cranking or twisting. We're doing a straight up bite kind of approach so that we don't fracture through the base of the skull. And let me just move on from that. So that once you've done that, then you want to see these pictures. Now, the one in the middle is one we've labeled. Unfortunately, our patients don't come with labels, but you are and will become more familiar with this. So you want to be sure before opening any of the skull base that you are quite clear on the cellar floor, on the location, and actually can visualize both carotid protuberances, that's the CP, both optic prominences, both opticocarotid cisterns. You want to see where the planum sphenoidale is at top, and you want to see the clivus below. That's the benefit that you're getting of this endoscopic approach, that is the inside of a sphere and not a flat disc. And that's really essential to the next steps. So then you'll be doing the tumor resection, in which you want to accomplish a wide exposure of the cellar floor, a wide, and I prefer an X-shaped dural opening in order to maximize our exposure in this minimally invasive approach. You want to be thinking about both intra and extracapsular removal in the larger tumors. And we have some special technical considerations in those cases that are what we refer to as malignant endocrinopathies. Those are patients who have acromegaly and who have Cushing's disease, where their lives will be altered and their lifespans will be shortened if we don't get it all. So we want to go the extra mile in getting every last bit out of those if we can. So we've all learned so much from Ed Oldfield. May he rest in peace. I've added his superb description of how one approaches Cushing's disease. And he had the largest series, and I have really considered his writings to be my primer on how to approach Cushing's disease. Because, of course, particularly with endocrinologically active tumors, your first opportunity is your best opportunity to remove them. So learning what he has told us about wide exposure of the cellar floor and how to systematically open the dura in that X-shaped fashion that I mentioned, and then to try to get to extracapsular removal, then you see this kind of arrangement on the right, where you're able to remove tumors and sometimes even a little daughter or satellite tumor and try to get it all out. And then finally, once we've mastered the resection of tumors within the cella, including endocrinologically active tumors within the cella, such as an acromegaly and Cushing's disease, then we have this whole exciting world of extended approaches. And that's beyond what I really want to go over today, but I do want to give you a sense of how exciting it is that we can now do what I'm showing in just a snapshot from the OR on the left, where you see the pituitary gland itself is actually being protected below your field of view. We've opened up into the lamina terminalis, and we're starting to see the undersurface of the frontal lobe. In this case, a meningioma of the tuberculum sella has been removed. And over on your right, you have even a better view of that, where the tumor is out, and from the extended transsphenoidal approach, one is looking at the optic chiasm and both anterior cerebral arteries and the anterior communicating artery. So it's very exciting to think about being able to remove these tumors safely for our patients through an approach that doesn't require a craniotomy. But there's a lot of technical considerations that are important, and those are primarily related to closure. We have very few unrecognized CSF leaks in standard pituitary surgery. But when we start talking about extended approaches where we're opening a large window in the floor of the anterior cranial fossa, we have to be certain that we're closing that well. We can hurt people with meningitis. So in those cases, you want to be sure you recognize the leak you've in these cases, the extended approach cases, you're purposefully creating a leak, of course. You want to be sure that you have a multi-layer closure. So an intradural closure, and I like to take a piece of fat from around the umbilicus. There's plenty of it in all of us. It doesn't hurt, and it's aesthetically pleasing. So then you have both that for both an intradural and an extradural intracellular closure. You want to close your sinuses well and manage the septum and turbinates in a way that the patient won't develop a postoperative sinus infection that, thanks to your recent surgery, can become encephalitis or meningitis. So this is the kind of thing that we want to be looking at. This is the, was anyone ever here before approach that we want to see as we're exiting after transsphenoidal surgery, where we are replacing the septum, we're replacing in that case, you see that's the superior turbinate. We want everything to look like we were never even there. Oops. So attention to detail, there are many different ways of doing this beyond the scope of our initial talk today, but attention to detail of closure is really paramount in these cases. And just like I mentioned, it may be the most senior person who is driving the endoscope. It may also be the most senior person who is attending to the details of closure here. A little bit different concepts from craniotomies, but very important. And then post-op care is important. Nasal care needs to be considered important. And remember to check the abdomen. We're not used to having abdominal incisions to look at in neurosurgery. We like to do labs on post-op days 1, 2, and 7, but by 7, they're always at home. So just a communication strategy so you're sure they get those labs and that they're communicated to you and you communicate back. Up to 10% of patients will have hyponatremia on day 7. It's okay if they have it, but you want to know about it and be able to advise your patients accordingly. We like to see patients back at 4 to 6 weeks with labs, and we like to get imaging studies at 3 months. And at 6 to 12 months, we assess the need for whether there will be a requirement for adjunctive stereotactic radiosurgery in the future. So as I close the topic, I want to be sure that you're all aware of the Fiends International Fellowships in Neurosurgery, that which Dr. Sekobunga, who is our host today, had in 2017, that which our last hope, Dr. Ignatius Essene, had with Dr. Dempsey in the recent past. These are really important both to the host institution and to the person who has them, because they are the seeds of long-term sustainable relationships, which is what, after all, Fiends and these new Fiends global visiting professorships are about. So we are actively recruiting applications for the Bassett and the CLAC fellowships every year. You can find information about them at fiends.org, and we are so eager to share these with you. There are a lot of them. I think I'm correct when I say that the largest source of international fellowships for young neurosurgeons in training come through fiends. What is the difference? The Bassett fellowships are those which you may think of as the traditional ones where individuals from perhaps a low or middle income country travel to a high income country in order to have a formative experience and then go back and use those experiences to create ongoing relationships between the two institutions. We are doing those virtually during pandemic, but there's a lot of evolution that will happen to make those even enhanced in the years to come. The CLAC fellowships are specifically designed to allow those who are training in a low or middle income setting, but we're very aware that quite often residency training in some countries requires tuition payments by the resident, which is not the case in North America, where residents are paid, never enough, but they're paid and they're able to live because they're employees. They are not tuition paying students. So the CLAC Family Foundation funded fellowships that help those neurosurgeons in training kind of get across the finish line to be able to help with tuition and living expenses if someone is in a national or regional training program and needs some help to be able to complete that. So with that, I'd like to close this part of it, leaving you all my contact information, but to also say how pleased that we at GW, where I'm from, we're celebrating our bicentennial this year, and we hope to be able to welcome many of you to campus virtually and certainly soon, not virtually, but in person. But I'm really just so pleased that we in Fiends with all of you are at the dawn of new partnerships through this global visiting professorship. So with that, I'm going to stop sharing and see if the gods of the internet have allowed Juliet, Dr. Sekobunga, to still be with us. And if so, to allow Dr. Sekobunga to be able to moderate any questions or comments that our participants may have. And Juliet, I can see that you're still there. I don't know if you have audio or not. You might, if you're still there, but can write in the chat, it looks like you've said thank you. You may not have audio. If that's correct, I will ask Dr. Ulrich Sidney if he has audio. And I know that we also have Dr. Robert Dempsey on. My guess is that he has audio as well. I'd like to open it up to anyone who has audio capability who would like to join the conversation.
Hi, Dr. Rosseau. Thank you so much. This was a wonderful presentation. My first question for you is, given what you've seen in the past, the history present of pituitary surgery, where do you think the field is headed in terms of technical advancements?
Boy, I'm so sorry, Ulrich. I can hear you, but there was an echo and I don't think I could hear your question. I might ask you to type it. And while doing so, if there's someone else who has perhaps a stronger internet connection and wants to ask an audible question, maybe we could do that now, and then I'll look in the chat for Ulrich Sidney's comment.
Gail, could you just take a moment to talk about the ease or difficulty of training people in these techniques, and what you try to do, especially with the endoscope, to improve their training as opposed to the way we would do it with the microscope?
Sure, that's a great question, Dr. Dempsey. And I will say that transphenoidal and especially endonasal endoscopic surgery is a different additional skill set from our other craniotomy approaches. When you think about microscopic neurosurgery, and we had an excellent example of that in our last Fiends Global Visiting Professor talk from Dr. Dempsey. When one is doing a craniotomy, and in his example, doing a Sylvian fissure dissection, we are all doing that through a craniotomy. We're generally seated at a microscope, and our hands are at 90-degree angles to one another. In the endoscopic endonasal approach, we are generally standing, not sitting. We are not looking in a microscope, but we're looking at a TV screen, and our hands are very close together. It's a chopsticks kind of approach as opposed to the cross kind of knife and fork approach. So it does require some practice in order to get used to that, because it's unique to the constricted nasal or endonasal environment. The way I learned was to do a transition period over about 2 years, where we went from doing the transbuccal transeptal approach, which is a wider transphenoidal exposure, but where we made an incision in the mouth from incisor to incisor, connected that with a transeptal approach in the nose, and that allowed us to put a speculum down the face of the sphenoid rostrum. And we did that kind of approach with a microscope during my training 25 years ago. And then we started bringing the endoscope in at that point and getting used to the endoscope, having the microscope on the side so that we would always be able to have good visualization at depth. That was very helpful to me. Likewise, practicing in the lab, which we have now, on cadavers and also on virtual simulators, which are really quite good for endoscopic transphenoidal surgery. Those are all useful, and I think that they're essential. So to answer your question, Dr. Dempsey, both a transition from microscope to endoscope and that constricted standing, looking at a screen environment, that's your own personal learning module, if you will. But then in addition, there is this aspect of the most experienced person is often the one who's not doing the operation, but the one who's holding the endoscope, who's kind of showing you, this is what you want to be looking at. That's similar to the two-headed microscope, where the senior person may be in the assistant's chair, but they're showing you what you want to be looking at and where you want to be working on that dissection. And likewise, it's really important to pay attention to the details of closure, because we can really hurt people with meningitis and encephalitis that they didn't need to have if we just get excited about the technique of doing the operation and not retain our larger excitement about restoring that patient completely intact and tumor-free to their families. I'm going to look in the chat here. Juliet was asking, are there any endoscopic skills approaches? offered to low-income countries? The answer is yes, and there will be more as we partner with more and more residency training programs. So the answer is yes, and they will be coming through CANS, the Continental Association of African Neurosurgical Societies. They'll be coming through COSEXA. They'll be coming through FEENS, and generally in partnership with groups like Incision and the GSSA and Intersurgeon. We're going to be seeing a lot more about this. So thank you for that question. From Professor El Mostarshid in Morocco. We talked about the learning curve. What about managing a carotid lesion during the procedure? That's everyone's worst nightmare, right? So you want to be sure that you are undertaking this operation in the setting of knowing what you will do if you have a carotid problem. The way to stay out of a carotid problem is to do scores, perhaps hundreds of cases first, in which you have seen and completely and accurately identified where the carotid arteries are before you actually, and I'm talking about where they are in the sphenoid sinus, before you start identifying where they are within the sella. As you know, somewhere between 5 and 10% of the time, the carotid is dehiscent. The bony carotid covering within the sphenoid is dehiscent, so you can actually see the medial wall of the carotid within the sphenoid sinus. And I would encourage you to get used to looking at it and looking at the carotid protuberance and the optical carotid cistern, so that it is you are absolutely certain where it is before you start removing tumors that will be within millimeters. As you will recall, the average distance within the sella from medial carotid wall to medial carotid wall is 14 millimeters. So you just have to be spot on in your angle in order to be removing these tumors without crossing the midline from one side to another. So it's possible, definitely possible. You can do it safely and securely, and it's a great advance for patients. But you can hear the caution in my voice, because we don't want the enthusiasm for the technique to outstrip our enthusiasm for safe patient care. Do you study the sphenoid bone before surgery systematically? Yes, I do. In the general sense, I review all sphenoid bones, and then I like to do a CT of the sinuses before the surgery, so that I know exactly what's going on. There are many variations to the bony detail of the sphenoid sinus, and I don't want to be surprised. I want to know before I go in exactly what I'm dealing with. From Brighton to everyone, a question about support for patients with Pan-Hypo pituitarism. This is really important. We want to be certain that if we're doing pituitary surgery, we have access to pituitary hormone replacement, pituitary hormone assays, so we know who needs replacement. And I'll give you a great example of something that's very exciting that FEENS is working on now in Sudan, where we have an exciting early partnership with the Sudanese American Physicians Association, who are supporting the development and expansion of the residency program in that country. You might have recognized the Sudanese flag in my own slides today. And one of the members of their board is a Sudanese American endocrinologist who is going to make sure that as these techniques are being introduced in Sudan in absolute lockstep with the neurosurgical learning of the technique, the development of the lab to learn the technique, the development of resources to accurately image the tumors, we're going to have assays to know precisely, in Khartoum, what in a timely way, what the patient's endocrine profile is preoperatively, perioperatively, and postoperatively. And that's really important. And that will come.
Gail, your talk is a great example that neurosurgery does not exist in a vacuum. As we look at these low and middle income countries, could we talk about the importance of building your endocrinology, your imaging, your critical care team, and some tips as to how they might encourage that growth in their own country? Because without that, something like pituitary surgery will not exist.
Well, Dr. Dempsey, you're absolutely right. And one of the things that we always emphasize in this and every neurosurgical setting is the recognition that our patients, our neurosurgical patients, are best cared for in an environment where neurosurgeons recognize that they are one member of a patient care team. And we cannot do it alone. In fact, the way we train our residents, there is a requirement that is called being part of a systems approach. And you actually can't graduate as a neurosurgeon unless you understand and effectively work within that system. So that means that you need to be able to work very well with the pathologist, the endocrinologist, the nurses who are saying to you, this clear fluid that I see coming out of their nose, I'm not sure if it's the saline spray I just gave them or it's CSF that's running out of their head. The rehab people, the ophthalmologists, we're used to being the captain of the team. We don't shy away from that responsibility, but a team is only as strong as its weakest link, and it is our job to make sure that every link is strong and that we are working productively, collaboratively with every member of that team. Now, specifically, as we talk about global neurosurgery, there are things that we'd love to have every neurosurgeon be involved in. Things like NSOAP planning, National Surgical Obstetric and Anesthesia Plans that countries like Zambia and Tanzania have written that are informing their ministries of health and their elected governments as far as how to spend their own sovereign budgets in order to have equitable access to global surgical, including global neurosurgical care. We want to be training neurosurgeon and physician leaders who are going to be able to help countries that are early on in this process develop systems of care for universal access to surgical care that keep in mind all the things that you all know and are studying about what is important in terms of systems in order to be able to have no line of care, line of service evolve in a vacuum or in a silo. There's another question from Nuru Dini Adinira and Bankol. Hi, Dr. Bankol. Nice to see you. Thank you for joining us. What do you think about the high rate of extensions in case of macroadenomas with cavernous sinus invasion and into the paracellar region? What do you think about complementary radiosurgery? Well, I'm very excited about complementary radiosurgery and also about the new technical innovations that are coming down the pike. I would encourage you to look up ZAP, ZAP, surgical, and others in that field. You know, we love stereotactic radiosurgery, but it's been expensive, and therefore there's not been equitable access to it. But we're involved in the development, and we're talking about months to years, not decades, of affordable stereotactic radiosurgery platforms that I think are going to transform neoplastic growth care in Africa for neurosurgeons and other surgeons as well. It's very, very exciting. So it's coming. As we think about whether there are any other questions, I want to mention that again, as we did at the outset, that currently the FEANS Global Visiting Professor program meets every 2 months. And the next one will be Dr. Peter Nakaji, who is the chairman of neurosurgery in Arizona. And that will be in the month of May. And you'll be hearing more about the date, the time, and his host in the next days and weeks to come. There's another question in the chat, again from Professor El Mostarshidbi from Morocco, asking about the learning curve, lab, and cadaveric. Now, I will say that I think both cadaveric learning and simulator learning is important for endoscopic endonasal approach. And let me tell you why. It's specific to this route of approach. The bones are very important. And so cadaveric dissection to look carefully at identifying the sphenoid sinus rostrum, the nearly infinite variety of septations within the sphenoid sinus, and looking at the bony lateral walls of that sphenoid sinus, which of course are the medial extent of the carotid protuberance. All of that is really, really important. And getting that mind's eye of where the two sphenoid sinus ostia are, so that you're just smack dab on that window of bony exposure. And there's just nothing like doing cadaveric dissections, because bone is bone, and you'll be able to see the varieties of that bony anatomy that are so important in the skull base best in cadaveric dissection. Now, that being said, cadaveric preparation of the turbinates and the septum is usually really bad. In life, they are, which is your operating situation, they're mobile, they bleed, etc., and they don't. In a cadaver, they're just like pieces of clay, which does not at all simulate the situation you'll have at surgery. So for the soft tissue component of this exposure, I think that the simulators developed by Stryker and Storrs are really good. They brought them to the last pituitary course that we offered in Abuja 2 years ago. And I know they're available on the continent, and we will work hard to have both available as we did in Abuja at the Cannes meeting that Dr. Raji Mahmood hosted, and we will continue to do that in our best equipped pituitary courses in Africa in the future. I see that we're at the top of our hour. I want to respect everyone's time. If Juliet is still there with audio, or Ulrich Sydney, I'll pass it back to you.
Gail, I'm going to take the privilege as one of the many learners today to thank you for this very informative talk. This is an area of great importance, which is not enough available in the low and middle income countries. And it represents our goal of elevating the care of patients worldwide to these problems that neurosurgeons can uniquely take the leadership role in. So thank you for leading us through this topic today. I learned a lot, and I hope our colleagues did as well. Thank you.
Well, thank you, Dr. Dempsey. And we'll close by saying that this was recorded. The video will be hopefully edited and then made available through all of the online platforms that would be useful to this intended audience. Thank you, everyone. Join us again in 2 months. We're very grateful for your comments and participations and partnership. We look forward to staying in touch. Bye, everyone.